Next on the list, we'll ask Dr. Brilakis to come back, and Manos is going to speak to us about drug-eluting stents, state of the art. Manos.
So we want to make a challenge for you. So we have me speak several times this first session. If you make it through this, that means you're really strong. So stents means a scaffold, then a polymer, and a drug. You cannot read this, but there are 3 drug-eluting stents currently available in the United States. We do have the Resolute, the Promus Element, and the Zeiss Expedition. So all of them, they use a limus drug, and they're all second-generation drug-eluting stents. And that's what second generation means. Second generation is the stents that came after the first one, which were the Cypher and the Taxus. These were approved for the first time in 2003, 2004, so about 10 years ago. And one of the problems they had, as you can see here, they're big. So the stent strats were much bigger than the ones we're using right now. Also, there was much more polymer than we have now. So there was more stent, metal, there was more polymer, and there was more drug. And now we've learned that using less metal, less polymer, less drug, you can actually get better results. And this is some of the drugs that are being used, which are essentially the limus drugs or paclitaxel. Paclitaxel comes from the bark of the brevifolia tree, so it's a little harder to find. But essentially, these are the 2 classes of drugs that we currently have used in drug-eluting stents. And what all those drugs do is they stop the replication of a cell. For the fellows and for the boards, the main difference in mechanism is that the paclitaxel inhibits the microtubules, whereas the limus drugs inhibit different parts of the cardiac cycle. That's a favorite board question, so just keep it in mind, both for cardiology and internal medicine for that matter. And what is very interesting is that currently, actually, the drug elution, which means the rate with which the drug is being released, is very similar. With most current stents, most of the drug is actually released over the 3 months. So we've learned over time that you don't want too long, because that's toxic. You don't want too short, because then you get more stenosis, but you want it just right. And the right, it seems to be about 3 months. So there are several generations of stents. They keep on improving, having new designs and new stent delivery systems. So this is an example of the Zeiss Prime stent, which have a shorter tip and a different balloon system that's more deliverable. This is another example from the Promus stent, which also has a thin strat and has fewer connectors. One of the complications with stents has been stent deformation, which happens when you try to advance a balloon through a deployed stent. Now imagine you have the vessel, you put the stent in, and sometimes you can get what's called accordioning effect, where you push the stent and you can deform it. And that can happen with various types of stents, with the ones having less connectors being the ones more likely to have it. So it's something that's important to keep in mind. However, there are now new designs that are designed to mitigate this effect. For example, there's this Promus Element stent that has more connectors in the proximal end, which is exactly where the balloons hit the stent, whereas it keeps fewer connectors distally, so it keeps its flexibility and ability to move around bends and be deliverable. How about different drug-eluting stent comparisons? I mean, these comparisons can easily put you to sleep. So I'm going to go very fast through them because there are million studies and there's so-called DS fatigue. So even amongst interventional cardiologists, we've been exposed so much over a decade to comparative studies that everyone is starting to kind of go away and kind of miss the point. But here's some important ones that I think are worth knowing. One of them is the PROTECT study, which was the first study with the primary endpoint being stent thrombosis. For those of you not in intervention, stent thrombosis means you have a stent, and then for some reason, which can be the patient didn't take the medication he should, i.e. clopidogrel and aspirin or ticagrelor or prasugrel, or because the stent wasn't very good to start with, or for some other undetermined reason, a blood clot forms acutely in the stent. That's a life-threatening event. It's an ST elevation myocardial infarction. People can die from this. So it's something that's very important. I want to minimize it because although it's not very common, when it happens, it has very bad implications. So the PROTECT study compared a second-generation DS with a first-generation DS. And what it found is that during long-term follow-up, there was actually less stent thrombosis with the second-generation DS, although there was an opposite trend in the first year. So it looks like the second-generation DS with the friendlier polymers and less drug are less likely to get stent thrombosis down the line, which is something very positive. Moving on to another study. Now, the currently used sotarolimumab eluting stent, most commonly, it's called the Resolute. And this was compared with the Zion stent, which is another very commonly used stent. And in the Resolute all-comer study, what was found is that the incidence of major adverse events was very similar in the two, as was the risk of stent thrombosis. Again, as I mentioned, there are many, many studies, so I don't expect you to remember all of them, just 1/3 maybe. But what essentially all the studies shown is that the second generation DS seem to have similar outcomes. So you have studies showing that the everolimus eluting stent is better than the first generation DS, but in terms of the second generation DS, there are fewer studies. And this is sort out 4 showing the same thing, that the everolimus eluting stent had less stent thrombosis compared to the first generation DS. So this is a common theme. Second generation DS are safer than the first generation DS. And as you know, there's a DAP trial that Dr. Mixon will likely mention down the line that now trying to understand, is longer term dual antiplatelet therapy better, or should we just stick with a shorter, especially with these new second generation drug-eluting stents. This is to show you that, again, everolimus stent has less death, myocardial infarction, and target lesion revascularization, as well as stent thrombosis. So again, we have a lot of data now showing that second generation DS are better, and stent thrombosis is one of the major components of them being better. Now, people are saying, why don't we use a polymer that then, after a certain period of time, can go away? So you don't have the long-term adverse effects of the polymer on the vessel wall. And there are many such stents that are approved in Europe and in Asia. However, there's none in the United States. So this is more some things are going to come. One example of those stents is the biometric stent, which was compared to the Cypher stent. And again, promising results showing that over a long period of time, stent thrombosis seem to be less with those second generation biodegradable polymer stents. Moving on, there is the Nobori stent that also had similar results with the everolimus eluting stent, so very good, excellent safety profile. And there are more coming down the line. One important thing to keep in mind is that a new finding is that stents now, many of them, they have the polymer not all over the strut, as we used to do in the previous generation stents, but now they're trying to put the polymer on the so-called abluminal surface. Because if you think about it, you have the vessel wall, and the part of the stent that faces the lumen, you don't need drug there because there is no lumen, there is no hyperplasia of the muscle cells happening there. So you want the drug to be concentrated to the part of the stent that faces the wall of the vessel. And this is what is going to happen increasingly. So Synergy being one of those stents currently in development. There are also stents that take the polymer completely away. This is an example of such a stent that essentially sprays the drug directly on the metal that has a microporous surface. And by doing that, then you don't have to worry at all about having a polymer. And again, in this study, it was similar outcome to the everolimus eluting stent. So again, very promising. However, given that US lags a little bit in terms of development, this is not yet available in the United States. There's a common problem with all the stents. Every metal stent you put in, the one problem is that if the vessel wants to grow, it cannot, because the stent is there and doesn't change over time. Second problem is, if you want to image, for example, with CT or with MRI, there's a problem because the metal doesn't let you essentially look into the stent lumen. Another problem is that you cannot do bypass. If you line your LAD with stents, then the surgeons cannot plug a lima, which is a very important graft for survival purposes. Also, the stents, we're now finding out that the longer term they stay there, they may actually have the so-called neoatherosclerosis, which means the stent now develops, the vessel develops new collateral deposits just inside a recently placed stent. And that's actually more common with drug-eluting than bare metal stents. And finally, if you have a piece of metal sitting in the vessel wall, even 1, 2, 3, or even more years after implantation, you still have the risk of a blood clot forming inside the stent, which is a foreign body in terms of the vessel wall. So to address those limitations, there is a new stent, it's called Absorb, that is made of PLLA. So essentially, it's like a plastic stent that has the important, and that's how it looks like, that has the important property that actually it can dissolve over time. So over 6 months to year and a half, the stent gradually degrades. So it gives you the support you need earlier on, but then gradually gets absorbed. And then 2 years down the line, you don't have any stent left into the vessel. Again, this stent is now undergoing clinical trials in the US, and it's approved actually in Europe and Asia. And that can actually create extra opportunities for interventional cardiologists, the classic example I like to say is CTOs. CTOs will know you put a stent, the vessel is going to grow. And when the vessel grows, the stent you put is going to be undersized for that size of the vessel. So having a bioabsorbable stent can help you actually support the vessel when you need it. When the vessel grows, stent goes away, and everything is good. The other thing, if you put a bioabsorbable stent, is that the vessel are not a static structure. It's not like a lead pipe. The vessel is designed to expand and constrict in response to exercise, whatever you do in daily life. So if you have a metal cage inside your vessel, this cannot happen. But if you have a stent that goes away, then your vessel can actually shrink or expand because the stent is going to go away. So there are many potential benefits of having an absorbable stent. But again, please hold tight. Maybe in Dallas CVI 2020 we'll have it, but it's going to take a while. So to summarize, we do have currently excellent stents with very low event rates. The second generation DS we're using have much less stent thrombosis compared to the first generation DS, and that actually help us address more and more patients with complex coronary anatomy. There is a very high likelihood that things will continue to evolve. We'll have novel stent designs that make them more deliverable, and in the future, they will have a bioabsorbable polymer or they will be completely bioabsorbable, and that can further improve the clinical outcomes. So I'm going to stop here and thank you again for your attention.